Chairman, you're gonna have a crowd.
I know we got a quorum. If you would, please have a seat, and we'll give everybody just a minute to settle down, and we'll get started. I'm going to call the meeting to order. This is our Health Subcommittee of Appropriations, and we're going to be talking about the budget. And so we're going to go right ahead and get started. And first up on our agenda is Commissioner Frank Berry, Department of Community Health. So, Commissioner, we'll turn it over to you and your team, and we'll be glad to hear from you.
Great. Thank you, Mr. Chairman, members of the committee. It's good to see everybody. I will be very brief in my comments and turn it over to Lisa in just a moment to walk through our amended budget. I did want to let everybody be aware, we brought several of our subject matter experts today so that we'll have time for questions if that's acceptable to you all. I thought it would be great for you to hear from some of our leaders of the department if there are specific questions. Blake Fullenwider is here from our Chief Health Policy Officer. Joe Hood is here, who oversees HFRD. And of course, Mario, our Chief of Staff, is in the back with Brandy, and then Lisa and Kelly are here from Budget and Finance. So we'll be prepared. I did want to just remind everybody that we recognize that we are a regulatory compliance and finance department, and sometimes that gets a little frustrating to people. We are working very, very hard with our team to get them to understand that just because we're regulatory compliance and finance doesn't mean we can't say yes. And how do we get to say yes more often? So we're really pushing the department in that regard. CMS poses us some challenges with that. We have to stay within those guardrails. But when we can get to a yes, that's our desired outcome. So we'll continue to do that. If you all hear of challenges that some of your constituents are faced with, please call, and we'll try to help out in any way that we can. Then I'll finish with our 4 primary areas of focus for this past year have been teamwork, customer service, communication, and accountability within the department. So we've been pushing the department in those areas as well. So I'll turn it over to Lisa to walk us through the amended budget, and then we can certainly answer any questions that anybody may have.
Good afternoon. As we usually do for the Department of Community Health, I just give a brief overview of the agency's budget for this current year. The Department of Community Health has a $15,649,092,261 total funds budget, with $3,484,882,913 of that in state funds. The majority of the funding appropriated to the Department of Community Health is in benefits. 97% of those funds are budgeted in Medicaid as it relates to Age Blind and Disabled Program, Low Income Medicaid Program, and Peach Care. Moving into the budget for the Department of Community Health, I will start with Departmental Administration, beginning with item 17.1.1 of a workload adjustment of $4,901. Those workload adjustments for the amended year have to do with statewide changes as it relate to the Department of Administrative Services for a self-insurance program that usually OPB appropriates to all agencies to continue with their operational costs as it relate to that. 17.1.2 is a reduction of personal services for projected expenditures in the tracking sheet of the amount of $201,343, and that $201,343 relates to vacancies that we are holding available in some personal services reductions in our Department of Administration program. 17.1.3 for a reduction in contractual services. These are our hourly contracts that we can manage by the hour as it relates to various contracts within the Department of Administration to help us and assist us with the operation of the Medicaid program. And that's a reduction of $703,656 as it relates to that reduction. 17.1.4 is a transfer right from the start Medicaid to the Department of Human Services, and that was effective on November 1st of 2019. And that transfer led to a reduction of $2,544,383 in the Department of Administration budget, with a transfer of that to the Department of Human Services. Going into our next program is Georgia Board of Dentistry, and that's 17.2.2, and that's a reduction of funds projected in that program, and that's related to personal services as it relates to vacancies at the beginning of the fiscal year. In dentistry, Board of Dentistry of $33,744. The next program is 17.3.1 in pharmacy, and that's also a reduction in that program of personal service and vacancies that was held available in that program. And statewide changes were also in both as it relate to those premiums being paid to the Department of Administrative Services. The next program is Healthcare Access and Improvement, and you will see statewide changes throughout, and those are what the Department of Administrative Services administered self-insurance programs are related to. So you will see that throughout our programs in community health, and it's a $92 ad there for Healthcare Access and Improvement, and that's our State Office of Rural Health in Cordele. 17.4.2 is a reduction of one-time funds for the Rural Health Systems Innovation Center of $462,908 in that particular program. There are statewide changes being added to Healthcare Facility Regulation, which we refer to as HFRD, of a workload adjustment of $2,725 ad for administrative services for self-insurance program. The Indigent Care Trust Fund, 17.6.1, that's where we pay our disproportionate share hospital supplemental payments to private hospitals. And we usually ask for a state appropriation for that because they're not eligible for intergovernmental transfer from any of the hospital authorities as to draw down the federal funds for that. We will move into our benefits program as it relates to age, blind, and disabled, and low-income Medicaid and Peach Care. 17.7.1 is an increase in growth for the Medicaid age, blind, and disabled program of $65,267,880 as it relates to the age, blind, and disabled program. 17.7.2 is an increase in funds for the hold harmless provision for Medicare Part B premiums. And these are the premiums we pay on behalf of the dual eligibles, those who are eligible for both Medicaid and Medicare. And that increase is $6,780,737. An increase in the Medicare Part D clawback payment, which is 17.7.3, and that is the premium payment we pay for the prescription plan for those who are dual eligible for Medicaid and Medicare, and that amount is $3,936,297. The next item is 17.7.4, and that's to replace nursing home provider fee with state general funds. That's a zero impact, where we do revenue estimates, where we submit them to the Governor's Office of Plan and Budget when we project either an increase or a decrease in nursing home provider fee, and it's usually adjusted with state funds. The next program is Medicaid, low-income Medicaid. The first item is 17.8.1, is for the reduction of growth in the low-income Medicaid of $109,568,690 for growth in low-income Medicaid. And you will also see an adjustment there as it relates to the tobacco funds. We were replacing $5,721,600 in state funds with tobacco resettlement funds, settlement funds in that program. an increase in growth in peach care, which is 17.9.1. There's an increase in growth that is being projected for the peach care program of $5,717,740 for that particular program. And that would conclude our presentation for Department of Community Health regarding our appropriated budget programs. But we usually give you all an overview of the state health care benefits financial status as it relates to state health benefits. And that's actually on the slide, if you can see the slide. Well, we give how we closed the past year, which is fiscal year 2019, and projected out 2 years, which is 2020 and 2021, as it relates to the revenue and expenses coming into the program. And as you can see, in fiscal year 2019, we had a total of $3,854,233,186 of revenue coming in the state health benefits, but we expensed $3,369,425,229 of expenditures, leaving us with a net surplus of $484,807,957. And you can see how it rolls forward in terms of our OPEB reserve and SHBP reserve listed at the bottom. The 2 out years has a operating deficit in both 2020 and 2021, as you can see on your handout.
Thank you, Lisa. So, Mr. Chairman, members of the committee, we can certainly answer questions. Before we get into that, I did want to recognize that certainly we've heard very loudly and clearly that there are discussions to be had about PBMs. We're looking forward to being a participant in those discussions. We also recognize through HFRD that there are issues regarding personal care homes and assisted living facilities. We've got some subject matter experts here today to talk through some of that. We're looking forward to meeting and discussing with Chair Cooper and members on the other side, on the Senate, to talk about ways to improve the overall program in that area, and can certainly talk a little bit about that today, although we may not have all of the answers. And then I wanted to remind everybody that 97% of our budget goes to pay claims. And so we're a flow-through for a lot of the work that we do. The admin budget of our department is pretty small when you think about 97% of our budget goes to claims. So I'll turn it over to you for any questions.
Okay. Do we have some questions? Representative Petrie has a question for us.
Thank you, Mr. Chairman, and I have 2 questions if I have the chairman's ability to ask. First of all, Commissioner, thank you. As you know well, I have the utmost respect for this department and its leadership, and you're right, 97% of all of these revenues going straight to claims is a powerful statement. A couple of things. First of all, you alluded to one of them, but first of all, I want to ask if, and this may be a difficult question to ask off the cuff, $65 million in increased funds for Medicaid-based projected need as it relates to ABD. Can you help us to understand where that projected growth is with different programs, classes, if you will, of program members that we serve?
Sure.
That's the first question.
Okay. In the age blind and disabled program, that's mostly driven by the cost of services in terms of category services that's being utilized within the age blind and disabled program. And that particular growth is, we also look at enrollment as it relates to projecting out the cost. As it relates to age blind, disabled, we look at Medicaid inflation and trends nationally to go into that projecting out the cost. But this particular growth item is really driven by cost of service, the category of service within age blind and disabled.
Okay, so it's the cost. It's not necessarily. It's obviously not new individuals served necessarily on certain waivers, things of that nature. It's more about the aggregate cost of serving that population, and that ABD population in the aggregate is growing.
Yes, sir.
And as we continue to age, that's going to continue.
Yes.
Is that fair?
Yes.
Okay, and Mr. Chairman, if I may, one last question. So the commissioner alluded to an issue that relates to healthcare facility regulation, and I want to ask a question. So there has been a lot of conversation about the HFRD's ability to regulate and survey all the different entities that it surveys. It's such a vital service, and obviously, in the position that I'm in, we want to make sure that all the long-term care world is adequately surveyed. We want to make sure that we keep the frailest of the frail, and again, this department is all about protecting the frailest and the most vulnerable in our society. Want to make sure that we're doing that, and by the way, my history with the department is they do a phenomenal job with HFRD, and I have tremendous respect for the leadership there. But my concern is this: when we're talking about cuts to budgets, help me to understand the degree to which we are adequately staffed today at HFRD to adequately survey personal care homes, assisted living communities, community living arrangements, skilled nursing facilities, daycare facilities. Help me to understand that where we are there in terms of our staffing today, and are we cutting anything there that could harm our efforts there?
So I'll turn it over to Joe in 2 seconds. From a 30,000-foot standpoint, we were able to work very closely with the Governor's Office of Planning and Budget, and HFRD did not take any cuts. So that was a very positive step. There's a couple of nuances before I turn it to Joe. One, there's a significant difference in how nursing homes are surveyed and the federal requirements for nursing homes versus personal care homes and assisted living facilities. There's federal regulation that kind of overlaps with nursing homes, and then there's more state oversight that relates to assisted living facilities and personal care homes. So I just wanted everybody to kind of get a big picture of that. So although they both fall under HFRD, they're distinct programs, and different teams do those surveys in a little bit different way. So Joe, I'll turn it over to you, and certainly the expert will give you more detail on that.
Thank you, Representative. So my name is Joe Hood. I'm the Chief Compliance and Technology Officer for the Department of Community Health, and our liaison with our Health Facility Regulation Division, which oversees the facilities licensure and complaints and compliance that you're referencing. Specifically, I think what the Commissioner is discussing is to make clear that we represent it correctly. So when we talk about state licensure, that would be assisted living and personal care homes, and those have only the state regulatory guidance that the legislature has passed and that we enforce through licensure and then through the complaint follow-up. So that staffing is significantly less than what we have on the federal side, which oversees the nursing homes and skilled nursing. And that's also, for the funding is different, of course, as well, because the skilled nursing, the nursing home, has the federal regulation, and that guides through a Medicare contract, which is a predominant funding source of what is surveyed and how frequently and how that is done on the nursing home side. So the comparison is we have about twice as many on the skilled nursing side for nursing homes because of the complexity of the regulation and the training that's required there for staff positions. On the state facility side, we have half as many, and we have a lot more in number that we have to regulate when you look at the whole complexity, because it goes beyond this. It goes beyond assisted living and personal care homes. We have X-ray and other licensure types that are state based that we have to survey. What I will say in regards to staffing on the state licensure side is we have adequate staff to meet our statutory responsibility. And certainly we do that, and we show that in the metrics, and that's been our stance and Melanie Simon, our executive director, has brought forward how frequently we've done that and so forth. But the complexity is less, right? And I think you see that, and that's some of the criticism that's out there. But it's a different environment. It's supposed to be personal care homes and assisted living are at a much less needy population that require less care and less oversight, mostly ambulatory in personal care homes and to a large extent in assisted living. When you shift to skilled nursing, of course, that's not the case, and you have registered nurses and a lot greater level of care that is being paid for by Medicaid in many regards. So we're on the state licensure side. I think we have one vacancy presently. We're fully staffed. It's a different type of staffing. We have very few nurse requirements on that side.
Right.
On the skilled nursing side, we've been protected for funding, the commissioner and the department working with OPB. As you see in the tracking document, HFR was not impacted at all. We're in a separate budgetary program, and it was not part of the 4 or 6% proposal. However, we do have a challenge in recruiting nurses, and we have a large nurse vacancy rate for skilled nursing. I think that's a challenge throughout the state, though. I mean, there's a nursing shortage for RNs and for LPNs throughout the state of Georgia, and it's impacting us in that regard in maintaining those and maintaining our rate of survey in nursing homes. That's probably our greatest challenge at the moment. I hope that answers your question.
Thank you.
Just to follow up on that same issue, my constituents read the Atlanta Journal, Constitution and Journal, whatever it's now called these days, and they've been reading about things that are going on in some of the assisted living environments, and are asking me what we are doing about it, what we are doing to fill the gaps, and what we are doing to make sure that the laws that exist are actually enforced, and that people, if there are issues, there's a real system for making sure that they're fined and required to make changes. And if you're saying to us, we feel relieved we didn't lose any money, that doesn't help these people who are worried about where their parents, and, you know, I guess my kids are gonna be worried about where I'm gonna go pretty soon. So, I mean, what can I tell them?
So, well before the AJC articles came out, the department, with your support last year, was able to get the background checks legislation passed.
That's
And that
helpful.
was a first bite at a big apple. And so that was done last year. Throughout the year, we've been working with other agencies, even as recently as the Georgia Council on Aging, with Chair Cooper and members of the Senate, to look at how we strengthen the overall oversight. And so what we have conveyed and what our board at DCH has conveyed is we are a piece of the puzzle. We're not the whole puzzle.
Right.
And so there has been dialogue. Our website was just updated over the last several months so that people from a transparency standpoint will have readily available data that can help them make an informed decision of where they want to have their loved ones live. Those types of initiatives take time. So like I said, well before the AJC articles came out, the state and the department was looking at how to improve oversight of the system. And again, legislation was passed last year. There was legislation that was passed my first year at DCH, but it's a process. And so while I know that that's not a great answer to give to a constituent, it's reality that you cannot totally dismantle the whole system. We are working very closely with the provider associations on, we don't want to do something, pull a lever here, and then all of a sudden, okay, this place has to close, and with 24, 36 hours notice, where are you going to put 150 people? So we have to balance all of those things before we do a reaction to something that we didn't fully understand what the unintended consequences are. There are providers in small communities who, if you implement X, Y, and Z, we know they'll go out of business. Now, some of them may need to go out of business, but what about those that are really putting forth effort to remedy a quality issue? How do we make certain that they're still there for those people in those small rural communities who desperately need that? Again, with us making certain that we're providing the quality oversight.
May I follow up? So I heard the person responsible for this mention that you were meeting statutory responsibility. Is there some statutory change that would be helpful so that we might ameliorate some of these situations that have been pretty devastating for families?
I think working with you all and working with the governor's staff and trade associations, I do believe that there will be legislation that could help with the overall compliance and oversight. We're looking forward to being a part of that discussion. You know, I think a lot of times people want to hold a person accountable. And it's a systemic issue, and so we want to be a part of the solution. And I know there's been some discussion about everything from looking at new categories of service that will require higher staffing patterns. We think that might be a good idea. We are looking at fines and looking at what goes on nationally as it relates to fines. I think there are people who say, look at what this state does. Well, that state may do things a little bit differently, and I want to do something that's specific to what Georgia needs. And so, again, I think that between experts in the field, both nationally and at the state level, we'll be able to come up with some, working with you all, it won't be department legislation, but working with you all and your colleagues, stuff that we can all get behind and feel good about in regards to strengthening that.
We'll look forward to that progress.
Thank you.
Other questions from anybody? Representative Stevens has a question. Not right now.
Thank you, Mr. Chairman. As you, probably most of the people in here know, a lot of the grocery stores are getting out of the pharmacy business because of course, the margins have been squeezed by the PBMs, and I think that's going to be a conversation we're going to have later. My problem with that, of course, is we're beginning to eliminate some access to patients all over the state to pharmaceuticals. So as we go down this path to shed some light, if you will, just wanted the department to keep that in mind, and I'm sure Blake will do that.
Yes, thank you.
Commissioner, I got a couple of questions, and I don't know if you want to answer this or maybe one of your team can do it. It was mentioned earlier about the shortages of nursing and your turnover and this sort of thing. And of course, we're hearing that all over. Hospitals and everybody else has problems recruiting nurses. So I guess my question is this: is it a true shortage, or is it such that your ability to pay makes your positions non-competitive when you're trying to recruit nurses to come and work with your department?
I'd say it's both. I'd say it's both. If you remember through your support, several years ago, we were able to increase the salaries for our nurses that were looking over long-term care in our nursing homes through HFRD, and we were able to be competitive for about the first year to year and a half. As the economy has improved and continues to improve, we have lost a lot of those nurses to the private sector. They can just pay $10,000 to $15,000 to $20,000 more dollars a year than we're able to pay. I also believe, and from some of the nursing schools that we've spoken to and some of the deans of the colleges of nursing, we do have a shortage in our state. We absolutely have a shortage, and so it's both. So how can we get creative to attract more nurses? How can we, from an incentive standpoint, and we like to be a part of those discussions as well, but I do think it's both.
Well, as we go forward, please keep us informed as far as your turnover rate and your ability to attract, and if it's a situation that your salaries are just not competitive and you're not able to get the personnel that you need, then we need to have a discussion about that.
Thank you.
One other question I have for you, Representative Stevens touched on it a little bit, but there seems to be some consolidation in the CMO world that's going to be going on, and I'm just wondering, when this happens, is there looking at the distribution of the patients that the CMOs have so that it's basically sort of evened out and you don't have one that's really big and one that's really small or something like that? Could you talk to us about that a little bit?
So certainly DOJ, I think just in the last week, approved that merger. We are keeping an eye on it. We're looking at what has gone on in other states to see if CMS and DOJ have weighed in on that topic. We're in the beginning phases of figuring out what that will look like in Georgia. Contracts will be up for renewal in the next year and a half to 2 years, I believe. And so there's going to be that issue that comes up as well for us. Blake is here, and certainly I want to make sure I'm not missing anything. So we don't have a firm answer on what that'll look like yet. We just have not gotten far enough down the path to have a definitive answer, other than we know it's a concern. We know we'll have to make a decision on that, and as we continue down that path, we'll keep you informed on that.
Good. Well, I think that's something, there's a lot of interest in that, so we certainly want to
Yes.
work with you and see where we're going with that.
Great.
Representative Gardner has a question for you.
Thank you, Mr. Chairman. Predictably, I think we need to find some ways to bring more money into the system of healthcare. We have 500,000 people in Georgia, adults, many of them mentally ill, as you very well know, who simply are not eligible in our Medicaid program. So as you look forward to what other states are doing, it is troubling to me that we are looking at spending $200 or $300 million on a waiver that will cover a few people, when we might be able to spend close to that same amount of money of state dollars and bring in significant federal dollars. So it continues. I mean, I'm not a mathematician, but I understand basic arithmetic, and it seems to me you would use $200 or $300 million to cover 500,000 rather than 50,000. So I know that Mr. Fuhlenwalder is not surprised to hear me say this, but it's important that we think about spending our money wisely. And for me, it is basic arithmetic. And our hospitals and doctors need to be paid for the services that they're providing. And where is the money going to come from?
Thank you.
I just want to comment on the PBMs. Blake is teaching me daily about PBMs, right, Blake? As of even yesterday, we met about that. So there may be a light at the end of the tunnel, and you may like that light when we get through.
Thank you.
I've got one more question. Lisa, would you expand a little bit on the state health benefits slide that you had, and what's happening? The dark numbers are turning to red numbers there. Could you talk to us about that a little bit?
Sure. Usually, not usually, but within the state health benefit program, the revenue that you see that comes into the program is the employer share of that pays into the program that agencies receive to pay on behalf of those employees. It's also premiums that the employees pay also. And the expenses that you see there are the claims that we pay on behalf of those who are in SHBP, and that includes active and non-active teachers and non-certs who are also participants in the state health benefit plan. In the projected out years in terms of fiscal year 20 and 21, what you actually see there is that expenses are outpacing the revenue coming in, and that's the reason you see it go from black to red. In fiscal year 2020 of $192 million in the red, and in 2021 with $314,000 in the red. So if you look at that operating deficit, so we're not going to be able to pay, but yes, we will be able to pay, because out of that 2.9 million you see in the projected year, 700 million of that is SHBP reserves. And the difference of that is the 2.2 billion of that is OPEB reserves for those who are post-employee benefits for retirees. So those are reserve funds that's there if we have to go into the reserves to pay for the operating costs, especially with the SHBP reserve. OPEB, it operates a little bit different in terms of it's there just for the retiree post-employee benefits. I hope that added a little clarity to it.
You're just paying out more than we've got is what we're doing. I understand that.
I think, again, one of the challenges, Mr. Chairman, is healthcare costs for that population have continued to increase as well. We have been instructed to look at our overall plans and make sure that we are getting the bang out of the buck for them, and Jeff Rickman, our SHBP Executive Director, is working with our contracted providers on that, and we understand the urgency.
Thank you, Mr. Chairman. I think the Commissioner may have just answered my question. My question was about those expenses as it relates to the State Health Benefit Plan. I mean, those are substantial increases over those next 2 years in terms of your baseline expense there. We're not adding a lot of new state employees,
That is
that's for sure. So my question was going to be about why, and I think you just alluded to that. But
So, and remember, state employees plus teachers. So while our state employees are pretty
we are adding
stable,
teachers.
We are seeing an increase in the volume of teachers, not a significant increase, but it is primarily driven by expenses, healthcare expenses,
So this-
pharmacy costs.
Okay.
There's about top three: diabetes, pharmacy. Blake, what am I drawing? The other drivers. Yeah.
So obviously, I mean, our school enrollment continues to grow. We deal with that every year, obviously, in this budget. And so we're hiring new teachers. And so that largely would be attributed then to teachers. Is that fair? I know there's a lot more to it than that. You're talking about additional costs, particularly with certain diagnoses, I understand. But a lot of this is, in terms of new enrollees, is going to be teachers.
I would say
Is that right, Ms. Walker?
teachers make up more of the plan than state employees, and also
Right.
non-certificated employees are there too in terms of school personnel. They are also
Gotcha.
part of the plan also.
Gotcha. Thank you.
Would part of that, the answer to some of this be that the amount of money that the employer is paying in is less than we paid in earlier?
Yes, that's correct. Actually, the percentage that the employers paid in dropped July 1 of last year compared to the previous year.
Yep, thank you. Representative Gardner, you had a question?
Last question. It's curious to me, when you list the expenses, you talk about baseline expenses. I figured out that MA means Medicaid Advantage, but mental health is separated from a baseline expense. Why is that separated out? It is a place where I see a big increase.
That expense that you see there was added to State Health Benefit Plan in 2019 to comply with the Mental Health Parity Act. So we added some additional services there, and it was just placed there in terms of the expenditures that was the first year expenditures for 2019.
So between 19 and 20, that's the cause of the big increase? Is that what you're saying?
From 2019 to 20, we projected that to increase in terms of the utilization of those services. Some of it was residential treatment. Some of it was autism-related services related to State Health Benefit Plan. And I want to say it was 3 services we added. I want to say maybe ABA, but I can follow up and give you that because we created a one-pager on that one.
Yeah, I would be very interested in seeing what the breakdown is. I know at the beginning, the autism expenses weren't nearly as much as you projected, but perhaps the pickup has been greater. So thank you for that.
Okay, do we have any other questions? All right. Commissioner, thank you very much.
Thank you very much.
Okay, next. Thank you.
Thank you.
Appreciate what y'all do. Next, we're going to hear from the Georgia Board of Healthcare Workforce. LaShawn Hughes is the Executive Director.
I'm ready. Thank you, Mr. Chairman. I'm here to talk about the Board for Healthcare Workforce. Our name was changed last year from the Board of Physician Workforce. So the purpose of our board is to address the healthcare workforce needs of Georgia communities. We support development of medical education programs. We work to increase the physician and other healthcare workers in underserved areas. We produce reports, and our main value add is we also provide loan repayment programs. This was our next slide, which is gone. FY 2020 original budget. It was our original budget. And before I say anything about our cuts that's coming, I just want to express that the board really gave careful consideration about these cuts, and we tried to cut them across the board and make it as fairly as we could. 17.11 for administration. This is our program for employees and our data collection and our research. We reduced telecom by 20,000. We cut our personal services budget 80,000, and also we had our name change, so it's a $100,000 cut from administration. Our next slide just talks more about what we do in administration. 17.12 is graduate medical education, and our first 17.12.1 is a cut for accelerated track program at Memorial Health, 273,358. We reduced our statewide residency fair where we go out, and we had one big fair in Atlanta. It was not successful, so we will not pursue that again. And we reflected $14,000 cut for contract. So the total in graduate medical education is $327,961. So our graduate medical education, this is where the funding goes for that. For example, we have 271 residents under contract, but there are 342 programs, available slots for them. And the reason for the difference is our programs are growing. We have new programs coming online like Northeast Georgia, Hamilton Medical Center, Kennesaw State, Wellstar Kennesaw is really growing. So those are the programs that are growing that will fill those slots that we have. Last year in the appropriations, it was put in Rural Surgery Fellowship, Rural Surgery Initiative, Fellowships for Vision, Cancer, and Neurology, and Child Adolescent Psychiatry last year, when we currently do not have any slots in those. And this is just a snapshot of what all the GME programs look like for 2019 through 2020. It talks about approved accredited positions, 3,274. And as I said, our programs are continuing to grow. We'll fill those slots. Currently, we have 2,818 slots that are filled. And our new GMA programs coming online, as I just mentioned, Wellstar Kennesaw, they're growing. They're going to have 172 new slots that will come online in family medicine, emergency medicine, and OBGYN, general surgery. So these are some examples. Our South Georgia Medical Education Consortium will have family medicine, general surgery, and OBGYN, and they hope to have 81 new slots that they'll train. And we hope to keep these folks. And Gateway Behavioral Health in Savannah has a psychiatry program, and they hope to fill 24 slots in that program, which is relatively new. So the Mercer School of Medicine operating grant, we reduced the funds $961,596 to take their operating grant in 17.13.1. So the next slide shows what the Mercer operating grant is. It talks more about the operating grant. Mercer has 3 campuses, 473 students, all are Georgia residents. We hope to be able to keep all of those people here. Since they started here, we're growing them here, and the plan is to keep them. If you go over to our next slide, it's Morehouse School of Medicine. 17.14.1 is $1,157,269 that we reduced from their operating grant. And on the next page, it shows what Morehouse, talks about Morehouse, their operating grant. Morehouse is here in Atlanta. They have 400 total students, and 258 are Georgia residents as well, which they hope to keep in Georgia if they match. Our positions for rural areas is 17.15. 17.15.1, we reduced our loan repayments for physicians, dentists, APRNs, and PAs by $500,000. 17.15.2 is the malpractice premium that was put in for physicians and dentists. So we're reducing that, and that brings us to $630,000 a reduction. And if you see our next page, physicians for rural areas, it shows where our physicians are, where the counties that we're recruiting physicians. The reds are 35,000. The yellow is new. We've added for 50,000, and we pay physicians 25,000 a year, up to 4 years, and APRNs and PAs 10,000. Same thing, up to 4 years, and we also do dentists, 25,000. And our physicians for rural areas, we originally had 50 awards available. We received 57 applications this year, and we will be able to fund 37 of those. And for dentists, we had originally 15, we received 21, and we'll fund 12 of those this year. 25 APRNs, we get a lot of the nurses that apply for this program. It was 88 applications received, and we were able to fund 20 of those. PAs, 25 applied. Original awards, we have 41, and 20 will receive it. And our GP LRP is a federal matching program, and we will award 7 of those this year. And for malpractice, we were able to give 2 malpractice awards last year to Clay County and Hancock County. So we have not made those awards yet, but it's 2 people that, and others that may possibly could get that. So our GME exit surveys shows the reason our loan repayment programs are so important. And this is just for physicians. So out of 568 people we surveyed, over 88 had over $350,000 worth of debt. And if they managed to stay in our rural areas for 4 years, they could get $100,000. And sometimes hospitals or practices will match that, help to match that as well. Our undergraduate medical education, 17.16. So this, we reduced funds for medical student capitation. So we've cut funds from each of the programs, Emory, Mercer, Morehouse, and PCOM, and our cut was $170,700. So our next slide just talks about our undergraduate medical education program. Students in Georgia medical schools must be certified residents of the state of Georgia, and we help pay the hospitals $6,360, the schools and hospitals $6,363 for each student, and our participating medical schools are Emory 113, Mercer 210, PCOM 150, and Morehouse 96. And there was a one-time fee put in for the development of the campus for PCOM in Moultrie. So our next slide shows a summary of all of the cuts that we've made. Our original budget was $82,438,160, and we cut $3.347526. So the recommended, our end budget would be $79.9634. So as you can see from our sheet, we cut every area that we have. We went across the board and took something from everyone, and that's how the board voted to do their cuts. That's it, Mr. Chairman.
Okay. I think we might have a couple of questions for you.
Okay.
Representative Taylor, I believe, is first.
Thank you, Mr. Chairman. If you would look at 17.11.2, reduce funds for personal services to reflect projected expenditures. Can you explain to me what the personal services are?
Those are salaries.
Okay, so.
So positions that are not filled.
Okay, so that actually it's a personnel. You're doing away with a position?
That's not filled. Currently
Okay,
not
is
filled.
that one, two, or how many, and what were the jobs? Do you know?
So we were put in additional funding to do additional data capitation for nursing, well, not for nursing, but for the boards that we have. But we were able to use the people that we already had for
Okay,
that.
so that is not really eliminating somebody that's currently working.
No.
You're not reducing hours, you're not taking away a staff position.
No.
You've been able to gather the data without more people.
Right.
Okay, if I could continue. When you talked about some of these reductions, I'm very concerned because a lot of these are things that were added for rural communities, and I'm seeing a reduction in how it's going to affect our rural communities. I know the Mercer School of Medicine taking away $961,000 is a major hit, and I know that there are different programs that we're using. This is their workforce. How are we going to be able to continue or begin to get our residency programs going? How is this going to affect the overall programs that these medical schools are providing? As you know, down in my area is the PCOM. They're just getting off the ground, and now I feel like we're taking away funds that were enabling them to even operate in South Georgia. So these are very big concerns to me, and I feel like a lot of it is at the expense of our rural communities.
Yes, ma'am. We did ask the programs. So when we knew we were going to have to make the budget cut, we reached out to all of our programs and asked the question, how would this impact your program? So Mercer said so they sent for FY20 the proposed cuts to Mercer operating grant means less funding toward the Macon campus, the Savannah campus, the expansion of the primary care accelerated track programs, and the rural health initiatives at a loss of almost $1 million in total. So that would be their impact. So everybody provided us an impact statement for what the cuts meant to them.
So we will have less primary physicians coming out. They will reduce what they're going to do on the programs that they were just starting in Columbus.
She said less funding toward Macon and Savannah,
Okay.
and the expansion of the primary care accelerated track programs.
Okay, and some of the, I guess 17.15.1, it's reducing loan payments. It appears to me that these are being utilized. Do we have funds that are left over, or do we give away? Or are these now, I got the idea, you said that you had 57 applications and 50 were being able to be funded, and that's going to drop down to 37. Has anybody looked at how that's going to affect, again, rural communities? These were folks that were going to be working in very needed areas.
Right. And
Have we analyzed that at all, where the hurt is going to be at?
well, when we took the 500,000, you want to talk about that?
Good afternoon. I'm Freeman Montague, the budget manager. I'll try to see if I can answer that as best I can. So just to be clear, this was additional funds. So just as you asked earlier about personnel, if we were cutting anybody who already received them, we would not be. So the recipients who received funds last year, I believe it was 37 then as well, none of them would be losing it. We just would not be adding any more. We had already planned to have, I believe, 13 dentists, 10 APRNs and PAs, and 3 more dentists with the 500,000 that we proposed when we had the 2% enhancement option. But with this proposal that we have in now, then those additional would not be coming on.
So this was new money.
Yes, ma'am.
It's new money.
Yes, ma'am.
And may I add that we tried to cut all of the new money that had not been
Right.
funded to make
And
the.
where was a lot of the new money going? Rural communities.
Yes.
Thank you. I have no more questions.
Thank you, Mr. Chairman, and Madam Director, thank you. I want to talk to you a little bit. I want to talk to you about these loan repayment fund cuts, which has been a priority for this committee for some time. But first, I want to talk to you about take somewhat of an exception to what you began with. You began and ended by speaking to fairly distributing these budget cuts. Everybody take the same cut. And personally, I don't know if that's the best way you should cut. If an individual at home were cutting that way, they might cut paying their rent and wind up without a house and still be buying pizza. So we need to make sure that we're cutting strategically onto things that don't harm our community any more than they have to. And so when I look at 17.15.1, $500,000 out of this loan repayment program. So, so speak to me about those cuts and about how we've fairly distributed these in the most equitable way. It's not about this program cuts this much and this program cuts this much, but where are we going to lose the most impact? We got to make sure that we don't lose all of the momentum we've gained with some of these initiatives that we've fostered here. Can you speak to that, please?
Yes, and I probably did not use the right term to say we fairly cut. We looked at all of the programs across the board, and the board decided a way to cut instead of taking it from one program. But for the $500,000, since that's funding that we did not have the year before, we felt that that was an area that we could cut in order to keep the people that are currently in the program without cutting the existing programs. It just cuts the new people that would come on board.
That's fine, Chairman.
Oh, I'm sorry, I didn't hear you. I'm sort of deep in thought, and I may ask you some questions that Representative Taylor asked you, but I too have concern about the cuts to the loan and the malpractice areas for these rural areas. It appears that we don't have anything for malpractice. Am I seeing this right?
Right. We have two people that applied so far. It's the two people wanted to renew in Clay and Hancock.
Yeah.
And so we have the applications if the funding is left in the program, but
So we got to find the money for you. You know, a lot of this is the information takes time to distribute through the students. It's sort of the school's talking to them, but I remember 40 years ago when they were talking to me, and I didn't hear half of what they said. And you're trying to get through classes and deal with the rest of life. How about the other programs here? I mean, it's the student loans. We had it, we took it away from the dentist and reduced it to the physicians, and now we're starting to go backwards again. It just concerns me. LaShawn, I enjoyed being with you in Gainesville. You are a very special person. You do a great job, and I know that you don't like doing this, but this is painful for me to see us having to do this to these folks. It's sort of a yo-yo effect, and eventually it's hard. I mean, they make plans, based on what we're telling them we're going to do. And then we're helping them after they do it, and then we say, well, never mind, I know you're talking about these are cuts for new folks, but still, it's pretty hard on them trying to build a system out in rural Georgia. So if we can find some money to fix this, we're going to look for it, I think. But thank you.
Thank you, Chairman Hawkins. I got a revenue source for you. We did need to start it yesterday. My question's on 17.12.1. As you might, of course, we spent the whole summer looking at rural economic development. Right. And this, as I recall, this accelerated track program at Mercer, I'm seeing two cuts for Mercer on here, which is over $1 million. that was a big deal to get these folks out of school, trained faster and out into the rural area. And every one of these students every student at Mercer Medical School is a Georgia resident. So that's on the top of my priority list. I'm just throwing it out there so that you can put it on your dartboard once we get you the revenue.
Yes, sir. Thank you.
The thing that struck me was on slide 17, and you looked at the APRNs that applied. We hear over and over again how we desperately need APRNs. And you were able to fund 20. Is that because of the amount of money, or is it because of the qualifications didn't match, or why would it be such a low number?
Most of it is because of the funding. So,
Because the funding was a limited amount to begin with?
right.
Yeah,
So
okay.
even before this year in the cuts, they always apply. A lot of the nurses apply. And some of them apply from Fulton County and they don't qualify, but we get a lot of applications because they have a good network for advertising these programs.
Well, we need nurses, so it seems like wherever we can help them out, we ought to be doing that, and it's a lot cheaper than a physician. Anyway, that one really jumped out at me. It's disappointing. And I know you're the messenger, not the...
Okay, Sean, I think it's pretty obvious that the message from this group up here, I'm not speaking for the group, I'm speaking for myself, they've all, I think, had their say too. It's pretty obvious that we're not excited about these cuts, and it appears that the cuts are all the new programs that we have added over the last few years. And we're going to take a long, hard look at that. I think we've done some good. And the program that Representative Stevens mentioned, this accelerated program down there where they go through that and they automatically get a residence in, we got a Georgia graduate doing a Georgia residence, and chances are pretty good that person's going to stay here. And I just have a concern about that how I know you were given numbers you had to get to, and I understand that. But I think we're going to need to take a hard look at this and some of these loan repayment programs. When we went around and visited the medical schools and the dental school, first thing we heard was the amount of student debt that they have when they get out. And we're asking some of these people to go into rural Georgia, practice primary care medicine, have a large patient base that would be Medicare and Medicaid, so they're going to be reimbursed at the lower level of pay. And with a big debt hanging over their head, it just doesn't make economic sense to get them to do that. So I think that's something we want to look at. And then where we've been able to have the new program started, especially like in psychiatry, there's a tremendous need all over the state for that. So we were able to get a couple of things going. I just don't want to see us back up from our momentum that we had going and get these people in there. And, you know, you and I have had this discussion several times about the number of Georgia medical school graduates who go into our residency programs. I think that we need to do something to try to get that number up. And I've sort of come to the conclusion that I think we just about have enough slots now. What we've got to do is make those slots more attractive to these people so that they want to do that. Now, at Emory and Grady and Augusta, you got a line around the block wanting to get in those programs over there. But in some of our other programs, it's not that easy, and so we end up having students come from out of state or offshore schools and come in here and do that. So as we work through this, I hope the committee will look at it and you'll think about it and give us some good ideas about what you think we might could do to enhance some of these positions that we have and do that. And all of our big programs are pretty much over the cap, so they don't want to do any more with what it's going to cost unless we can get our friends in Washington to give us some relief and give us some more slots for that. So I'll get off my box now and let y'all anything else you want to tell us?
Well, you usually ask me about why people leave Georgia, so I brought it.
Okay.
Okay, so so it's reputation of out-of-state programs, desire to stay in Georgia but did not match to a Georgia program, higher residence salary, family reasons, quality of Georgia residency program, Their specialty is not offered in Georgia. Military obligations, lack of osteopathic residence. So that's some of the reason why people leave.
Seeing any uptick in residents coming back to Georgia? I was looking at those numbers the other day, and we were trying to get those from the. Does it look like we're getting more residents, out-of-state residents, Georgia citizens, or students coming back? Have we made a dent into that number?
Well, this year we did a 5-year rolling average,
Mhm.
and a lot of the programs were below the 50%
Yeah.
for the 5-year rolling average.
Yeah.
Yeah.
So we still got some work to do on
We
that.
still have work to do.
One last thing. Next time you come, can you bring a physician or nurse? Because my watch has been beeping. My blood pressure, it's telling me my blood pressure's going up. I'm serious.
Yes, sir.
Well, one of the things I wanted to ask you a question about this too. You know, we had tried to come up with some funds to make sure that you had the ability to get the data in a more timely fashion so that we weren't dealing with really out-of-date data. Where are we with that? I know you've made some progress and you're working toward getting us timely information that makes more current sense.
Right. We finally got our questions changed to have a minimum data set, which is what other boards use as well, to drill down to where people are actually practicing. Are you in the practice 1 day a week? Are you there full-time? Are you practicing clinically? A lot of physicians hold on to their licenses and renew them, and they don't practice at all. And they don't say they're retired because they want to keep their license. I understand it. You can tell from the debt how serious this is. So we've changed all of our questions, and they're new for this upcoming renewal. And once we get the new data set rolling in, we're going to have a feed to the medical board renewal site so we could get real-time data on our visualization site. So we're working on that.
Do you have the personnel in your shop now to process this in a timely fashion to get you what you need or not?
We're fine for now. We're fine. We're also picking up the nursing data. So
Yeah.
we've just completed the nursing data to figure out where all the nurses are in Georgia. And so we've given the report to the nursing board to look at and to tell us what we need to change. And then we'll be able to tell you also where the nurses are based on their renewal data.
Let me ask that in a different way. If you had more resources, would you be able to get more timely information that would be more meaningful?
So the data comes from the medical board.
Okay, I won't ask you anymore. Okay, I got you.
Thank you.
I got you. Okay. I'm not gonna say it. Okay, anybody else got questions? All right, thank you. You want to talk to us about the medical board?
Yes. Please. I just want to recognize Lisa Norris is here. She's our Deputy Executive Director, and Jonathan McGee is our Director of Investigations. And I forgot to recognize Daniel Dorsey from the Workforce Board earlier. So you have it's a one-sheeter for Medical Board, but I also included our annual report and the newsletter, which talks about where our complaints are, how much funding we raise for the state. And I'll start with 17.17.1. It eliminates the fund for a medical director position. This was put in last year and then it was vetoed by the governor's office. 17.17.2 eliminates the funds for one contracted assistant medical director for $25,000. We reduce funds for travel to reflect our projected expenses, $5,000. And we reduce funds to reflect efficiencies gained through the implementation of our new computer system. The implementation costs were kind of expensive, so now that the system is up and running, we're going to save that. So our program net for our cuts is $250,314. We have our budget is 2.676801. And the board brings in revenue 7.91676. It's on the bottom, at the bottom down there. It's our revenue that we collect. So we collect revenues from renewal fees, application and other licensure fees. We have fines and enforcement costs and other administrative fees. So our other administrative fees is everything that we can imagine to sell, like our database, a duplicate wall certificate, a duplicate ID card. We used to give away your ID card, your wall certificate when you got licensed. You had that nice frameable. We charge for those now as a way to have money for operating costs. And you see our active license count, how many physicians are here. We just got, last year in the last session, we were given genetic counselors as a new licensure group, which we hope to start licensing at the February board meeting. We also had the telehealth medicine license, and this is just a physician who does not live here but practices telehealth, and the interstate medical compact, which we hope to implement. After this session, we did not get approval to do background checks, federal background checks, so we're working toward that, to implement that program. That's it.
Okay, have any questions from the committee? If every agency did as well as you did with this, we'd have more revenue, wouldn't we?
Yeah.
Good.
Yeah, so your collections would pay for all your cuts in your workforce.
Right. But we turn all of that to the general treasury.
Good. Any other questions or comments from the committee? Okay. Thank you.
Thank you.
Let's see, is Dennis Trotman here, Drugs and Narcotics? Yes, sir. Oh, okay.
Good afternoon, folks, Mr. Chairman and representatives. Hope y'all are well. Our agency is the enforcement arm for the Georgia Board of Pharmacy. For the Georgia Board of Pharmacy, and also for any facilities and places that have and can use prescription drugs. So that is our entire focus from our agency. We're only a 15-person agency, but so I will go down. 17.18 is the section that reviews our budget for this year. We had a 18.1 is a general funds, general operating expenses decrease, and that will come from primarily travel for agents, things we've done. Our agents go to different trainings around the state. We are pharmacists, so I'm a pharmacist, and we are peace officers as well, so we have to have the combination of training. And we're not reducing the training, we're just going to keep it more local. I have 10 agents in the field and one part-time, and they're spread out around the state. They work from their territories all around the state. So we will be reducing those, attempting to reduce those travel expenses primarily for training purposes, do it closer to home for those agents. The $184,940 reduction last year, we had you worked with us to provide monies for a new computer system, and as the language states there, it was considered non-binding, so that money we did not receive. Reduced fund and personal services, as LaShorn had mentioned, we had a full-time position, administrative position, that was not filled, so no one's losing a position, or we're not having to let anyone go, but we will lose that funded position. We have a part-time agent, a gentleman who had retired but came back to work for us as part-time, again, just to assist with investigations and inspections. We will be utilizing him less and less to help reach that number. Communications and telecommunications, that's primarily the $29,015 reduction. All of our agents had Surface Pro or tablets that we would utilize in the pharmacies so that we could provide electronic and real-time information. They all have work out of their homes. The majority of them, they also have a laptop. So what we did was we reduced those Surface Pro units and turn those in, for lack of better terms, and that's where that primary, the 29,000 for those units and for that upkeep for those units comes from. So that's a total cut 282,491 to our budget for the year.
Got any questions? Representative Hawkins, that you're like?
Turning in Surface Pros, so when they're in the pharmacy, doesn't that hamper them? Or are they just taking their laptops and they?
Well,
What's
until
the-
about 3 years ago, they are taking their laptops now, and of course that's
In lieu of?
in lieu of, and when they can, we still have some that do it on paper, like I've did for the last 20 years, and we'll just get it to the agencies after they leave and actually send it in. We're a paper agency primarily, and that's when last year we didn't get the computer system.
But the Surface Pro you could write on and then convert it to text, makes it a lot quicker and neater.
It
I've
was,
got
we
one.
had, we do not, one thing I didn't do is thank DCH and OPB. We are attached to DCH for administrative purposes, so we
Right.
do not have IT people,
Right,
anything like that, but their folks at DCH worked with us, their budget folks, and as well as the OPB folks help us identify where our cuts could come without having to cut.
how's
into
your
those personal
PDMP
services.
program doing? Is that?
2 years ago that went to Department of Public Health,
Mm-hmm.
and it did, our agency, and former Director Rick Allen was tremendous in getting that through. It outgrew us very quickly. You can imagine with 10 agents and 3 office staff
Right.
and no funding.
Right.
And so I think it's doing well, but it outgrew us, and thank goodness was moved to Department of Public Health where they could do a great job with it.
But don't you, in your visits, do you ever look at that, or I mean, are y'all totally separate from that information?
We are totally separated, so
From
we
that
can,
information?
but we can get the information actually without a search warrant. Kind of strange about us, or one unique thing about our agency that was in that law.
Right.
We can get that on a
You
subpoena.
can access it.
We can get a subpoena from the director, so I could get a subpoena for that information. Other law enforcement, so the medical board, there's several agencies, including Medicaid, that can do it via subpoena.
Right,
Other law enforcement, like your local sheriff's office, would have to get a search warrant
right.
for something. So we do certainly communicate with them, and I'm on the advisory council, which meets tomorrow, but in fact, so we do participate and work with them.
That's working pretty good? I mean, are you pleased with the
And I'm an old
functionality?
pharmacist. The information that's there, I've been a pharmacist since 1986, and when that came about, and now they've expanded it from 1 year of data to 2 years.
Right,
Anybody who wants to look, pharmacists aren't required
Right.
in certain physicians, but yeah, the information is tremendous
good.
and helpful.
Yeah, all right. Thank you.
Any other questions from anybody? Dennis, let me ask you something. Last year, we put in the money for this data management system, that $184,000, and refresh my memory on that. I'm thinking that this was gonna help you manage better so that in lieu of hiring another agent, you felt like with this management tool, you'd be able to use your agents more efficiently and more effectively. And is that not right?
Well, that is right. I mean, with only 10 agents, and we hired one in December of 18 and one in April of 19, 10 agents still covering 159 counties is not enough. That's just me saying that I could always use more people, but everything we've got, Chairman, is paper, literally. And so that computer system was hopefully to just upgrade our entire operation, because we literally use an Excel database and put those things in. So we don't have anything where we have reporting and the licensing that can tie it together electronically. We have to tie it together, all ourselves. And so that was the main purpose, was to bring us a little more modern, a little more into the...
I know you've got 159 counties, but how many area or places do you have to supervise, like pharmacies and other things too?
Well,
number-wise?
I believe the retail number of pharmacies is about 4,500. The 20,000, as far as personnel and people, you got about 15,000 pharmacists. I believe it's 24,000 technicians. Then they're out-of-state wholesalers, but they're in-state wholesalers as well. So,
You got a lot of folks.
yes, sir, there are a few.
Okay. Great.
And we do assist the medical board. Anybody that has, again, prescription drugs, we often help. In DEA, we work with
Good.
federal and state agencies.
Okay. Any other questions or comments? Thank you very much.
All right, thank y'all.
Next, we'll hear from Dr. Toomey in the Department of Public Health.
Good afternoon, Mr. Chairman, committee. It's good to see you again, and I'm sorry that I'm the closer on it's been a very long day for you, but I'll try to make this as scintillating as I possibly can. And I just wanted to highlight a couple of things from my presentation from last week, and one of the most important things to leave you with is that we have worked very closely with the health districts as well as internally on these reductions. They were not made capriciously. It wasn't across the board cuts. It was actually working together to identify what could be reduced without reducing services, and that was the key to the decision making. And to show you that this is actually a collaborative process, Dr. Audrey Arona, who is the health director in Gwinnett, who has the misfortune of serving as the district liaison to the department for the next 6 months, is actually here and is available to answer questions if you're interested. So every 6 months, this is part of our collaborative process to ensure that we have district representation on our leadership team at the state office. Our almost $700 million budget is about 60% federal, but that also means that there are some requirements for match and maintenance of effort, which made some of the cuts reductions particularly challenging, because we didn't want in this process to reduce any what we consider to be essential federal services as well. And the other thing that I mentioned is that 45% of our state funding goes to the districts. And so that's, again, a huge proportion of our total state budget actually is serving the districts in some capacity. And finally, I wanted just to mention that our 3 priority areas that we had talked about, including maternal mortality, infant mortality, and HIV prevention and care, were 3 areas that we deliberately tried to not touch in any way with reductions. And I think that's important to emphasize that, because I know there are a lot of concerns after my Thursday presentation that you didn't see budget ads for my priority areas, but that was not my mission. My mission was to identify reductions, but at the same time ensure that we were preserving service delivery in these critical areas and in those areas of what we view as particularly high priority in public health. Let me look at our reductions, our budget of reductions for this fiscal year of $10,994,668. And as I said, this was a very transparent process internally and with the districts, and with our goal to minimize any reduction in services. And I think in the interest of time, I'll try to go quickly, but I'd like to go through each one and just highlight, what these reductions were. The first one is adolescent and adult health promotion, which actually includes 9 smaller reductions, or 9 smaller items. One is an adjustment to our agency premiums for the Department of Administrative Services. DOAS has done that to all of our programs. You'll see that consistent throughout the budget. I'm not going to repeat that, so you'll just see it repeated with every program. We did reduce the funds for the 5 Coverdell Murphy stroke readiness stroke hospital grants. This was to provide telehealth services to 5 additional hospitals. We have 19 identified stroke centers now in the state, and this program had not started yet, and we thought this was an area that we could reduce at this time without reducing services, and hospitals had the opportunity to become a stroke center without this additional monies for telehealth services. We reduced the Sickle Cell Foundation grant by half. This did not reduce services for sickle cell. In fact, 150 individuals will still continue to receive sickle cell case management. The reduction was in areas for health fairs and educational outreach, but not for service delivery. And again, we felt this was an area that we could potentially reduce without hurting the service delivery in this for this critical area. Reducing funds for travel and supplies is another thing you're going to see repeated over and over again throughout all of our programs. And as I mentioned before, we had we became aware of some fiscal challenges in our admin, and so I actually implemented travel restrictions and critical hire review for all state positions even prior to this request for budget reductions. And what you're seeing and scattered throughout this budget are these benefits from those travel reductions and critical hire review and salary savings through that. Reducing funds for personal services, again, just salary savings. I think this question was asked prior. If you have a position and don't hire right away, that savings comes back, and that can be put towards this reduction. The reduction in funds to the Georgia Core is a little misrepresented. The intention was not that $300,000 would come out of Georgia Core in this budget year, but rather that the regional cancer coalitions would each be reduced by $60,000. And so that was five regional cancer coalitions reduced, but Core this budget year would remain intact, and that was the intent. It just was a little bit misrepresented or at least confusing on the budget sheet. We're looking at the clearly maternal mental health is an important part of our maternal mortality work, and we're actually going to just do a switch with our state funds for federal funds for a position in this area, so that we're going to be using federal dollars to pay for a position that's serving in this area, and we'll be able to take those funds and apply to the reduction. And in a similar vein, we're reducing funds for the Georgia SHAPE program, which you may remember was an obesity program. It's been in place childhood obesity program in place for many years in Georgia. We shifted the state funds and are using federal Prevent a Block grant for that $170,625 reduction, and that is the adolescent adult health promotion. Department admin is our current challenge, but we are some of the positions were reduced, included several in the office of the director were vacant, and so they were able to be just eliminated for salary savings, and plus an additional $357,000 again for salary savings of positions that we won't hire right away. I know that that my representative from Fulton is going to ask what this is in the formula grant to the Fulton County Board of Health. This represents a fix during the time that the Fulton County became a Board of Health, which we were delighted that this happened. The money for the district cadre was not put in the admin budget, but was put in grant and aid, so it was subject to reduction. We saved it from a reduction and put it should have been appropriately put in the district cadre, which is admin. And so this is just a budget fix from a prior year. The trauma system reduction is, again, small reduction related to travel and supplies that represents our efforts to reduce state spending from even prior to these reduction exercises. In epidemiology, there's a few things that I think do need some explanation. One is the Hep C testing kits. This is a program, an important program for hepatitis C testing and epidemiology. We're concerned about Hep C. There were some funds unspent. We felt we could take away some of the test kit funding, but still keep that testing going on. About 1,700 test kits are still available with these existing dollars as proposed, and the epidemiologists and others support operational funding that supports this is still in the budget. So so that program will continue. So the reduction is a 30% reduction in the amount of test kits, but an ongoing operations of the Hep C testing, particularly of concern in North Georgia. The reduction in funds to the Georgia Poison Center was actually mislabeled. And I need to explain this because I know there's some concern about this. The Poison Center reduction was $49,000 to be taken this year and next year. So this budget year and next budget year. There was a $40,000 consultant for epidemiology that was eliminated because it wasn't needed, but I just think because without knowledge what the program was, it was lumped together as a total reduction to Poison Center, which is part of Grady. So I wanted to make that clear that this is a reduction of the Poison Center of $49,000 and then a further reduction of epidemiology. The total Poison Center contract is about $1.2 million. State dollars. They do have a Medicaid match, but it's state dollars from us, yeah. I wanted to talk about the infant and child essential health treatment services. The $55,000 of that was a contract with Emory Autism for training. It was training resident and field staff as part of an autism initiative that the staff felt that the training really was redundant and it would be ongoing. This wouldn't in any way have a negative impact on Emory's autism services, and we felt good about that this reduction could be taken without an impact on the ongoing important work that Emory is doing on autism. And then you'll see a $275,000 reduction, and that's left over from the WIC settlement. Many of you may remember that there was a WIC settlement that we had to pay back. This was some of the payback money that we didn't need, and so we can offer that up as part of the reductions. You know, I have to say that I know this was boring, and we're going line by line, but I was telling my poor CFO, who's been dealing with me on this, I felt like I was a Girl Scout again selling cookies, because you sell one box, 2 boxes, 3 boxes. I mean, these are small reductions in an effort to not to have a minimum impact on service delivery, and in the end, they still have to add up to 4% and 6%. And so I know this is tedious, but it represents the process that we went through and the real effort we went to try to identify as best we could the minimum impact on service delivery with our partners and internally with our internal programs and counties. The infant and child health promotion reduces a contract for a $40,000 reduction in the Marcus Autism Center. The $300,000 still remains for service delivery. That reduction was for a navigator, patient navigator, which they're actually not going to be using anymore. We felt very comfortable we could take that reduction without an impact on services. And then one vacant position, which was a nurse position, that was eliminated in a reorg. It was vacant. Again, that's a reduction without impact on services. In the infectious disease control, we looked at, again, travel and supplies, the ongoing, that ongoing work that we've been doing. We also reduced and eliminated a purchase order for STD drugs, which for reasons that were unclear to us as we went into the budget had not been utilized for years. And so it lapsed year after year. We saw that as an area we could take that reduction, which was $275,000, and pick up the need for those STD drugs through the existing federal STD dollars. And then the funding for personal services reflects 4 positions, 3 STD positions that were in fact vacant, so that isn't affecting current staff, and we were able to just eliminate those positions. And then we made the decision with at the laboratory to stop doing parasitology. We were pretty slow at turnaround, and many of our districts were turning to Quest and outside laboratories to do the parasitology work. So this does involve 1 tech position and supplies. I suspect that the tech will either retire or move to another vacant position in lab. But that will free up those funds for that position with a salary savings of $56,000. The environmental health reduction is a little challenging as well, because it reflects salary savings from 3 positions that we intended to be taken this year, but not rolled into next year. Unfortunately, they rolled it into next year, and you'll see that when we go over. But these are 3 positions, salary that were not yet filled, so we rolled these salary savings into the reduction. It included 2 district environmentalists, as well as the state head of environmental health, and we'll just have to identify additional positions for reduction next year, since that won't be carrying over. And in the Office of Children and Families, we saw an opportunity to eliminate what was a standalone program that had kind of dwindled over time, and redirect our efforts to, especially for early brain development, into our evidence-based child health programs, particularly home visitation, Babies Can't Wait, and also through WIC. And we just saw this as a real win to actually expand these services beyond a couple of contracts, which is what these funds went to. And I've presented this to the First Lady's Child Health Task Force and others, and have gotten good feedback, as well as from the provider community that worked with us on these. Now comes the thing of great concern to all of us, and I hope Dr. Arona will, if you have questions, will be available to answer questions. And this is the formula grants to counties. I mean, there's I think 2 things that I neglected to say when I presented this last week. This is general grant and aid. The general grant and aid has maximum flexibility at the local level. And so Dr. Logan in Gainesville will be able to take these reductions in whatever way she feels they can best accommodate throughout all your counties. And there's flexibility in this grant and aid that there isn't in the program grant and aid. We also send out, and I didn't talk about this on Thursday, we also send out programmatic grant and aid, which are often federal funds as well as state funds, but it's for specific activities, and they're very clear deliverables. And that program grant and aid often includes things that you think of as health department services. It's the immunizations. You know, it's the breast and cervical cancer program. It's the WIC program. So the programmatic grant aid is untouched, and we, again, made a real concerted effort not to take any reduction in programmatic grant aid. It was in the general grant aid, which allowed the maximum flexibility at the local level. And finally, the counties have other opportunities to generate revenue besides the general grant aid, and that can be everything from the fees they generate from restaurant inspections, from vital records. Many of them have a vital records office. They as well have grants. Some of the counties have been very effective at getting grants from the Robert Wood Johnson Foundation and even from HRSA for Healthy Starts. So, you know, I think that again, recognizing that the counties are the heart and soul of public health. That's where the rubber literally meets the road in public health. We wanted to maximize the flexibility and minimize whatever reduction there was going to be, to allow them to take these reductions as best they could, given the magnitude of the reductions that we required this year. And last and not least, mentioning vital records, our vital records office had a reorg, had a vacant position. I was able to eliminate that position and get an additional $129,598. And that brings us to our grand total of about almost $11 million in reductions for this year. And I will be happy to answer any questions. And I'm sorry, this was tedious line by line, but it was what we did, and we did it in a transparent way.
Thank you, Dr. Toomey. We have a question from Representative Hawkins.
Yeah, I've got a personal history with the Coverdale Murphy. I did that legislation. Both my parents died of strokes, so my future doesn't look overly bright. Going back to that, I noticed you're reducing funds for the readiness. How's that going to affect our stroke program that we've been
It's not going to affect
building
it
it?
at all. It's not going to affect it at all.
Good.
This is just for this was new monies to initiate new stroke centers. So the 19 are intact. It doesn't touch the old stroke centers. This was just for new centers that wanted to come on board, and the funding was specifically to provide telehealth equipment, and so we won't be able to provide that telehealth equipment for 5 hospitals. But it doesn't touch the.
That is effective. I mean, that does affect the treatment for a lot of patients without that telehealth equipment, right?
Well, but the existing centers haven't been touched. I mean,
Right.
these are new centers.
Right. Do we need the new centers?
I think as many hospitals as we have available in Georgia is the best possible outcome for all of our Georgia's residents, particularly given the fact that many parts of our state aren't adequately served. But again, we saw this as an opportunity to not have an impact on current services.
Okay.
Any other questions or comments? Representative Gardner.
Chairman, and to the commissioner, who is my constituent, by the way. And this is not your first rodeo in this job. Is that true?
Actually, it is my first rodeo in this
Oh,
job
I
because
thought
I
you-
wasn't commissioner. And Chairman Parrish will remember I was director of public health, but I was not a commissioner. I had a commissioner over me, several commissioners, actually 4 commissioners over me, 3 governors and 4 commissioners.
Okay.
So I've never had to make these kind of reductions in this way. And in the old rodeo days, all vacant positions were swept. Things were kind of done for me. It wasn't my decision to make in partnership with our staff. And I can say as a health director for 3 years, I was never consulted on the state budget. I mean, so the fact that we engaged not only the health directors, but all of our leadership team, I think represents the transparency we tried to take. You can't make reductions like this and not impact services without knowing what exactly those reductions are going to do. And as you point out, we know the challenges in rural Georgia. We are dealing with them every day. So I think that what you see here, the Girl Scout cookie approach is the one that we felt was going to allow us to make these reductions with the minimum amount of impact.
I just know that over the last few years, we've worked so hard to try to beef up our Department of Public Health and each of the public health departments. This is a really tough pill to swallow, and I know you're the messenger, so I understand that. I also hear that you've had some time to figure out some ways to consolidate some things within the department and eliminate some duplication. You feel like administratively you've been able to make some changes?
We're really making, I think, some headway in this to try to improve services, and we have some effort. We're moving, for example, the breast and cervical cancer screening program, which is such an important part, particularly in rural Georgia, into women's health. And it makes absolute sense. The women's health program is the one that reaches out to the district programs.
Mm-hmm.
And so it didn't make sense to be kind of stuck off by itself in a program that didn't have that kind of capacity and existing relationships with the women's health coordinators in the districts and counties, which is who actually implements these programs for rural Georgia. So that's an example of the kind of things we're trying to do, and look at opportunities for us to look at even our structure at the state office to have that operate more smoothly. We recognize we had some, as I said, challenges administratively. We had a little help from consultants, but we also had a lot of help with internally looking at meeting together with our team. And we're restructuring a lot of our administrative activities, both under our new CFO, who came reluctantly from OPB, I might add. You may recognize him, Lee Wright, but also Roz Bacon, with whom I've worked for many years, including at Fulton County, who will be serving as his chief operating officer. And she's going to really help with things like contracts, which took sometimes overly long to get through. I think that's what you're referring to, because you've heard about that.
It is, and I would just like to encourage you to continue that, because of course, what we hear are the things that go wrong, and we want to help you figure out how to make it work better.
We're aware, and we don't intend to lose a dime of federal dollars because we haven't.
That's also the worry. Do you have
absolutely.
enough people so that you don't have to send money back to the federal government?
No, we want our tax dollars to stay here in Georgia Public Health. So, no, I'm very aware. That was certainly something we're challenged with at Fulton, and we don't want to see that, as you know, and we
Yes.
don't want that to happen.
Where we sent money back.
Yeah, $9 million as a matter of fact.
This is really a good presentation. Thank you.
Oh, no, thank you.
Thank you, Dr. Toomey. Any other questions from the committee?
No, thank you.
Thank you for being here.
No, thank you so much.
Okay, last on our program, Georgia Trauma Care Network Commission, Elizabeth Atkins, Executive Director.
Good afternoon, Mr. Chairman. Am I truly the last but not least? Okay. And this is definitely my first rodeo, so guidance appreciated here. And you have in front of you a sheet that is the Georgia Trauma Commission amended FY20 plan. So typically what the Trauma Commission does is we use the amended process to go after the reinstatement fees generated by the super speeder revenues, because we get a portion of we get the fees portion, which on the bottom of that sheet there, you can see that that was about 16.4 million. So the reinstatement fees total were just over 7 million. The commissioners got together, and out of respect for the governor's request for 4% reduction, the total ask for the reinstatement fees was 6.7 million. So what you see in front of you is a plan of how we would spend that money. Now, the day that the amended budget was released was actually the commission's meeting day. So they found out that of the 6.7, about 2 million or so was not included in this. So the total amount that we would get would be somewhere around 4.7 million. So the commission will have to get together again to meet to discuss this plan that they had originally approved for the spend for the reinstatement fees. This is probably, and even though I'm new to the commission, I've been in around the commission for a long time because of working in the various trauma centers around in Georgia. But this is probably one of the biggest spend and injections of rural funding that we've seen so far with the amended funds. And I do have my newly appointed Georgia Trauma Commission Secretary Treasurer, Dr. Medeiros, in the audience. So if the committee members would like to give us any sort of suggestions to take back as the commissioners determine where they will reduce that 2 million funds, we would certainly love to hear that. But it does include, again, as I mentioned, one of the biggest injections for level 3, which predominantly our level 3s are in some of the more rural areas, and level 4 centers. And one of the things that we wanted to do with level 3 centers is allow them to participate in some of the quality improvement initiatives that are going on in the country now with national benchmarking that didn't previously exist before. And we think this can really help improve the quality of care in some of these level 3 centers. And then Rural Trauma System, a startup grant, which precedent was set for a previous level 2 center that was stood up to get a startup grant. We'd like to think that with ongoing super speeder reinstatement fees that we can get year after year, we can really beef up the startup grant process for new centers that would like to come on board. Also, you see a pretty big dollar figure there for unfunded trauma centers. Currently in the state, we have 34 designated centers, but only 26 of them are funded because the funds only go so far, so you have to maintain what you have and then sort of balance that with how do we bring on additional centers into the funding scheme. And then you can see an increased base funding, which is a pretty significant amount for our level 1 and 2 centers. Dr. Ashley, our chairman, I know he's presented to this committee and several other committees before on his readiness survey study that we are funded currently at a level at about 7 cents on the dollar for readiness funds. So that's why you see those funds there. And then the pre-hospital equipment grants, we certainly want to make sure that throughout Georgia we can ensure that our ambulances, our 911 ambulances, those respond to scene calls, have the life-saving equipment that they need. And I wanted to add to you guys just some information that what you funded us last year was Stop the Bleed. We're at 93% completion for Georgia public schools for Stop the Bleed. So we have about 5 counties left. So we should have those completed by the beginning of the next school year. So we're really excited about that. And sorry, I'm nervous, but if you have any questions.
That's okay, very good. Any questions from the members of the committee? Well, thank you. There's some good information, and you have provided us, or the agency has at one time, a map of the state that shows the trauma centers and so forth. And
I carry that with me.
okay, but if you get that and make sure we get all of that, because I think that helps to point out some of the problems in the rural areas where, you know, in the metro areas, you're pretty well covered, like here in Atlanta with your level 1 trauma centers and level 2. So, but in some of the stuff, especially in southwest Georgia, there's some areas that are not covered as well as you would like or we would like. So if you could get us that map too, that would be helpful, I think, when they look at these numbers and everything like that.
Yeah, absolutely. We have a fresh, updated map
Good.
to include some of the recent changes in the system, so I will be happy to send that along to
Great.
Tara.
Any other comments or questions from the committee? Thank you very much
Okay,
for coming.
thank you.
Representative Mabel Thomas was here a minute ago, and I know she wanted to say something, and we weren't taking public comment, but certainly I wanted to recognize her if she had anything she wanted to say, but I guess she might have stepped out. But thank the committee for being here. Everybody was busy today. There was a lot going on. Thank all of you in the audience out there for joining us today. I know y'all had a busy day too, so thank you very much for being here, and we'll